Thank you very much for that introduction. Good evening, everybody. First of all, let me thank the organizers of ISACON Kerala 2021 for giving me this platform. My name is Dr. Nigel. I'm from the Sultan Qaboos University Hospital in Oman, and I work in the Department of Anesthesia and ICU there. The topic that is given to me is DNR or DNAR. These are all anesthesiologists' predicaments, and this is a gray area which we need to address. Firstly, let me touch upon a few abbreviations in resuscitation that we as frontliners in the OT, in the emergency, or in the ICU would come across on a day-to-day basis. So we'd see DNR, DNAR, AND, MOLST, and POLST. All these are relevant in various countries. You would not necessarily see everything in India, but I'm just bringing all these abbreviations into one platform so that you would be familiar with it in the larger scale. So DNR, as it suggests, a do not resuscitate order. It is a formal medical order that a patient can establish with their doctor. So it dictates that the patient does not wish to receive CPR or have their heart restarted in the event that their heart stops. So the order does not affect other life-prolonging measures like the use of feeding tubes, but it only applies to the concept of resuscitation. A patient may opt for DNR if 1. Resuscitation is unlikely to be successful. Resuscitation is unlikely to prolong the patient's life for very long. This is number 2. Number 3, resuscitation could endanger the patient's quality of life. Number 4, the patient has a terminal illness and does not expect to live for much longer. So in 2005, the American Heart Association adopted DNAR to replace DNR in their guidelines for cardiopulmonary resuscitation and emergency cardiovascular care. Physicians should address the potential need for resuscitation early in the patient's course of care, while the patient has decision-making capacity, and also encourage the patient to include his chosen surrogate in such conversations. So before entering a DNAR order in the medical record, the physician should, 1, candidly describe the procedures involved in resuscitation, like chest compressions, the likelihood of its medical benefit to the patient's clinical circumstances, and also the likelihood of achieving the patient's desired goals for care or quality of life to address any misconceptions that the patient or the relatives might have. Number 2, we need to ascertain the patient's wishes with respect to resuscitation directly from the patient when the individual has decision-making capacity, or from the surrogate when the patient lacks capacity. Number 3, the DNAR order should be tailored to reflect the particular patient's preferences and clinical circumstances. We need to reinforce with the patient, their loved ones, and the healthcare team that such a DNAR order applies only to resuscitative interventions as they relate to the patient's goals for care. And other medically appropriate interventions such as antibiotics, the dialysis involved, or appropriate symptom management will be provided as care-based or withheld in accordance with the patient's wishes or condition. The last thing that I'd like to mention is we need to revisit and revise decisions about resuscitation. So this requires adequate documentation in the medical records as the patient's clinical circumstances may change. We also need to confirm whether the patient wants a DNAR order to remain in effect when obtaining consent for surgical or other interventions that carry a known risk for cardiopulmonary arrest. This is something that we'll be touching mainly on as we progress in this presentation. We also need to document in the medical record the patient's clinical status, prognosis, current decision-making capacity, preferences with respect to resuscitation, and the physician's medical judgment about the appropriateness of resuscitation. Now, when the patient cannot express preferences regarding resuscitation or does not have decision making capacity and has not previously indicated his or her preferences, the physician has an ethical responsibility. Now, what responsibilities does the physician have in such circumstances? So, he can candidly and compassionately these issues with an assigned patient's surrogate, which is an authorized, and document the surrogate's decision in the medical record. He can revisit with the surrogate's decisions about resuscitation as the patient's clinical circumstances change, revising the decision as needed and updating the medical record accordingly, depending on how the patient's clinical condition changes. Seek consultation with an ethics committee or other appropriate institutional resource if disagreement about a DNAR order that cannot be resolved at the bedside. And when the patient's preferences cannot be determined and the individual has no surrogate, the physician should consult with an ethics committee or other appropriate institutional resource before entering an order not to attempt resuscitation. In our hospital here in Muscat, we have a protocol-based scenario wherein two consultants can sign the DNR record in case a patient has to be declared DNR. 4 ways in which DNR orders remain problematic today include: so DNR decisions occur too infrequently and patient preferences regarding resuscitation sometimes are neglected. These DNR discussions are delayed until it is too late for patients to participate in discussions regarding resuscitation. Number 3, the physicians do not provide adequate information to allow patients to make informed decisions. And also, physicians inappropriately extrapolate DNR orders to limit other treatments. So these are some of the problems that DNR orders encounter today. And there are some strategies to fix these problems, which is evidence-based. So one is changing the hospital culture and outlook to such policies. We can reform hospital policies on DNR discussions, mandating provider communication skills training to the healthcare provider as well as the patient and the relatives. And we can also bring about certain financial incentives, and these would actually help to improve fixing such problems that we encounter on a day-to-day basis in our clinical practice. Now, I spoke about DNR and DNAR, but what is A&D and what is the difference between each of this in short? So this is basically taken from Oshner Journal 2011, when you look at DNR, this is one of the most popular evidence-based material that you would find. So DNR, as we know, is do not resuscitate. DNAR is very similar to DNR, or a newer version, or like I was telling you, the American Heart Association has replaced the word DNR with DNAR, that is, do not attempt resuscitation. And then we come across this word A&D, that is, allow natural death. So what is the pros of each of these? So we know DNR is familiar to everyone. In most hospitals, you would come across the word DNR itself even today. DNAR is something that newer hospital systems should inculcate, because there is clearer language indicates only a resuscitation attempt, not that it is likely to succeed. So it's more clear. And A&D has, again, basically it affirms that the patient wants nature to take its course without CPR, ACLS interventions, unlikely to succeed. Now, what are the cons? So it can give the misimpression to patients and family that the attempt at resuscitation is likely to succeed, a false hope. It can also make patients or their family think they are deciding whether to live or die, even though in an end-of-life situation, all roads lead to death. DNR is less familiar than DNR, as I already mentioned. Now, A&D can be confused with the conjunction and, as you know, but the clarification needed in orders about what is not wanted and what is wanted. For example, we might need pain control, hydration, and everything. So this might not fit all situations. Now, most of the hospitals, as we know, use the terminology DNR even today, but AHA, the British Medical Associations, and policies, hospitals which follow certain protocols, especially when it comes to accreditations, So these hospitals might inculcate words like, or the terminologies like DNAR. So A&D is used by Hospice Patients Alliance and some other hospitals. Literature review, quickly I'll just brush through these. DMA all in 1996 reported long-term survival of 6.5% to 15% for those with inpatient in-hospital cardiac arrest. Pebedi et al. Reviewed 86,000 odd adult consecutive in-hospital cardiac arrest events and they obtained from 507 medical or surgical participating hospitals. In this, they found out the rates of survival to discharge were 14.7% during the night versus 19.8% during the day or evening. So obviously, resuscitation in the night saw a worse result than in the morning hours. And a meta-analysis of 42 studies from 1966 to 2005, comprising about 1,700 patients by Reesfield et al., found that only 2.0% of cancer patients post-cardiac arrest in ICU survived to hospital discharge. So you would see how post-cardiac arrest in the ICU, we have very, very poor results of prognosis for patients. Now, to quickly touch upon what MOLST and POLST, as I already mentioned, both are very similar terminologies, just that some of these are used in certain states in the United States, and we would not see that in this part of the world. So basically, medical orders for scope of treatment and physician orders for scope of treatment. So this is what you see on the right side is an example of a form for that, and it basically delineates what specific care should be administered or withheld at the present time for a specific patient as directed by a physician. So these forms specify what treatment you want to receive during your illness, and it's more specific. So both MOLST and POLST documents are printed on bright colored paper so that they are easily recognizable by healthcare providers and can be placed at the front of the patient's chart. So similar to MOLST and POLST, we have COLST also, that is clinician order for life-sustaining treatment. So all these are seen in different states in the United States. They just come out with different terminologies. I'm not going into the details of this. So there is something called as TPOP, that is transportable patient physician's orders for patient preferences. This is basically for the states of Kansas and Missouri. That is basically, I'm just giving examples. Now, let me come to the most important part of the presentation. What is the dilemma of DNR that we anesthesiologists face in the operating room? So if a patient has an existing DNR order, an anesthesiologist might need to withhold such interventions and even reduce the level of anesthesia and analgesia to ensure stable vital functions. And either situation could compromise the outcomes of surgery. Therefore, many physicians would like to suspend the DNR orders in the operating room to avoid these predicaments. And this approach is supported by the fact that CPR is much more successful in the operating room than elsewhere in the hospital. 65% of patients who suffered a cardiopulmonary arrest in the operating room survived to discharge, and 92% of those whose arrest was caused by anesthesia survived. This is again literature based. When should the DNR orders be reinstituted? After the patient has recovered from anesthesia, the clinical conditions that justify suspending the DNR order are no longer present. Hence, it often makes sense to reinstitute the DNR order when the patient leaves the post-operative recovery room when the patient's clinical condition is stable. For example, a patient might require mechanical ventilation or vasopressors for longer than anticipated, but still have an excellent prognosis for full recovery. So the American College of Surgeons have also given certain protocols. So giving anesthesia can be very similar to resuscitation. So for example, drugs to support the blood pressure and measures to maintain breathing are used in the operating room and in resuscitation. This is something that we all know as anesthetists. In the operating room, these treatments allow the anesthesiologist to keep you sedated and pain-free during the operation while sustaining your breathing and circulation. Now, if you have a cardiac arrest there, resuscitation is much more likely to be successful than in other circumstances. This I've already mentioned earlier through evidence. Now, when a patient with a DNR order undergoes anesthesia or conscious sedation, the DNR order needs to be reconsidered at key times during the admission. For example, when the patient comes to theatre, discussions with the patients or their surrogates are essential to elicit the patient's goals and preferences. Computerized reminders can help physicians carry out these reevaluations. And checklists of life prolonging interventions may clarify what specific interventions are to be carried out or withheld. Now, I'm just going to quickly run through this because this is basically part of the institutional policies in the US. So, a patient with DNR orders undergoing surgical procedure is likely to be at increased risk to suffer cardiac or respiratory decompensation related to a non operative patient. So, four ethical concepts are immediately important. One is non maleficence, that is our Hippocratic dictum: first, do no harm. Number two, beneficence, or to perform a good or moral act for the patient. Number three, the principle of patient autonomy to be maintained. Number four, distributive justice, that is allowing the society to provide medical resources to those best able to benefit from them. Hospital policies now I would like to mention for management of perioperative DNR orders. One is automatic suspension of DNR orders in the perioperative period. This is one concept. That is, this can avoid the potential of wrongful death lawsuits. And as I already mentioned, non-maleficence can be invoked to support that DNR is incompatible with anesthesia and surgery. Number two, we can make an informed suspension of the DNR orders during the perioperative period. So patients with DNR orders must be informed of perioperative changes to their resuscitation status. And the positive point of this approach is that patient autonomy is better protected at this point. And it's a superior policy to that of not informing the patients, as it necessitates a discussion. Number three could be DNR orders except for airway intervention. Okay, the rationale for this approach is that airway interventions constitute an intrinsic part of anesthesia and cannot be withheld when providing anesthetic care. And the positive aspects of this approach include freedom to perform anesthesia by the anesthesiologist, and there is discussion and education of the patient regarding differences between the respiratory and cardiac arrest. Now, one more concept, that is continuing all DNR orders during the perioperative period. So here, therapies may be withheld, including chest compression, counter shocks, vasoactive drug therapy, endotracheal intubation, and mechanical ventilation. So the decision to refuse intraoperative resuscitation does not exclude maximal therapeutic efforts. So maybe we can allow for therapies such as opioid receptor antagonists, some fluid therapy, pressors of mask ventilation. All this can be done. But regarding the principle of distributive justice, a resuscitation policy that allows patients with DNR orders to refuse resuscitation in the perioperative period would be expected to conserve our operating room and intensive care resources. So this is very important in hospitals that aim to save resources in populations. So to summarize, each department of anesthesia and ICU should have a policy regarding DNR orders in the perioperative period. Of the four choices, continuing all DNR orders during the perioperative period after discussing this with the patient or the surrogate should be priority. And ASA guidelines respect an informed suspension of DNR orders during the perioperative period if explicitly discussed with the patient or surrogate and if they agree. The policy allows airway management and other treatment options, as already I mentioned, and it will also honor perioperative DNR orders if the patient specifically states so. Thank you very much.